Pain Explained by Daniel Bruns, PsyD. Copyright 2016 by Daniel Bruns, PsyD. Part 1. Pain as a Biopsychosocial Condition. What is pain? That sounds like a dumb question, but sometimes simple questions are the hardest ones to answer. Let me give you an example. How would you define the word the? Now that's a pretty simple word, you use it all the time, but how would you define it? Sometimes simplest things are the hardest things to nail down. Defining pain is like that. Here's another difficult question. Suppose a patient with severe pain is told that all medical tests are negative. The patient may ask, is my pain real, or do you think it's in my head? This distinction between pain that's real or in your head is troubling. But actually this distinction makes no sense at all. Your brain is always involved in the experience of pain, so it doesn't make sense to divide it that way. If you think about how anesthesia works by putting your brain to sleep. If your brain is asleep, you feel no pain. That's how it works. So, is your pain real? The simplest way to answer that question is that if you feel it, the pain is a real experience. But what is it? So we're back to the question, what is pain? The simplest definition is that pain is a subjective experience that is part sensation and part emotion. Now that second part is surprising for most people. We don't think about pain that way, and yet that's what it is. So this is the hidden part of pain, but it's hiding in plain sight. Let me give you an example. Suppose you're in the kitchen and you touch a hot pan and you say, ouch, damn it! That sounds like an angry statement. And in fact it is. Pain and emotion actually share circuits in the brain, and so when you feel strong pain, it also activates emotions. That's just how we're built. If a person had severe pain and was totally emotionally indifferent, that would seem odd. So how are we to understand pain? There's something called the biopsychosocial model of pain. And this is a model that integrates biological, psychological, and social aspects of pain. And so if we think about what all contributes to a patient's medical outcome and resulting pain or lack of it, there are biological variables that contribute, psychological variables, and social variables. Now, this model has many implications, and to understand it, we need to begin with biology. So let's think about the biology of pain. This is a diagram of the anatomy of the skin showing all sorts of sensory receptors which do all different things like measuring touch or pressure, stretching. But I want to zoom in on one particular type of sensory receptor called a nociceptor. Now, a nociceptor is one of the most important sensors in the pain experience, although other sensors also contribute. But the nociceptor is designed to detect damage to the body or potential damage to the body. So the nociceptor is one of the places where pain experiences begin. Now this is an anatomical view. Let's switch to a schematic view, which may help us understand this better. Neurologically, pain is a multidimensional experience. And surprisingly, another thing that most people don't know, there are two parallel pain sensory systems. One is sometimes called the first pain sensory system, and it's most closely associated with acute pain. This pain is conducted by what are called A delta fibers. And there are several different types of pain sensors here. There are thermal, hot and cold sensors, mechanical, like pinching, and chemical sensors, like a bee sting. But there's also another pain sensory system, sometimes called second pain. It's more closely associated with chronic pain. It's conducted by C nerve fibers, which are a separate type of nerve fibers. Now there are also thermal, mechanical, and chemical sensors. There's also something else called a sleeping sensor. It's a type of nociceptor that does nothing until inflammation happens. Then it gets switched on. Now in contrast to the first pain experience, second pain is more of a diffuse experience. Let's think about the difference between these two different types of pain. First pain is a very sharp, localized, distinct type of pain. For example, suppose I said, close your eyes, I'm going to stick you with a needle. And you close your eyes and you can say, ouch, you just touched me on my left index finger near the fingernail. You could tell me within about a quarter of an inch where it was. You could tell me when it started, when it stopped, if it was sharp, if it was dull, if it was pinching, if it was hot, if it was cold. You could tell me all kinds of things about that. So it's a very distinct experience. Second pain is different. It's hard to describe. It's like a patient who says, well, I have back pain, and it's kind of like this aching, burning sensation in my back, but it travels down the back of my right leg and all the way to my foot, and it's kind of a aching, burning, tight, feels like needles, or it's kind of numb. Second pain is hard to describe. It's hard to locate. It's a very peculiar kind of experience, but second pain has a lot to do with pain intensity, whereas first pain gives you location and the information about the type of pain it is. So we have these two separate pain sensory systems. Each of these systems goes by separate nerves up into the spinal cord, where they go to like switching stations called ganglia. Now along the way, a nerve can get pinched or cut, and that can produce another type of pain experience. In the spinal cord, in the ganglia, there are things called glial cells which hold all the nerves together, but also produce neurotransmitters. All of this begins to regulate pain in the spine before the pain signals are transmitted up towards the brain. Now I say pain signals, but actually, technically, it's a nociceptive signal because it's not pain yet. It doesn't become pain until it reaches the brain. So let's see what happens when it reaches the brain. Now, here's a model of the brain, and first pain follows a fairly direct path into what's called the somatosensory cortex. It's a part of the brain that regulates sensation and movement, and there it's associated with self-protective behavior. If you touch a hot burner, you jerk your hand away. It's a withdrawal reflex. And so this type of pain is involved with immediate self-protective behaviors. Second pain is more complicated, and it takes a more circuitous path through the brain. It goes through the brainstem, where it's associated with arousal. Patients who are in pain can't sleep. It's associated with muscle tension and spasms. Patients say, I have knots in my muscles and spasms. That becomes a painful aspect. It's routed through the emotion center of the brain, where patients report feeling depressed, anxious, maybe angry. Pain is associated with a weakened immune response. Over time, patients start to think about their pain. Will I get better? Will I be able to work? What will happen to me? Will the pain continue? Patients also think about coping with the world. What does this mean about my job? Will I be able to support myself? Can I pay my bills? Over time, too, patients start to have memories about being in pain. If you've been in pain for a few minutes, that's one thing, but if you've been in pain for a few years, you have all sorts of memories of pain. And you may start saying things like, I am so sick of this, because it's been going on for so long. So over time, your experience of pain is affected by your memories of being in pain. All these different aspects of pain are pulled together by the brain's pain center in an area of the brain called the anterior cingulate. Over the course of time, the brain may become more sensitized to pain. This is called central sensitization. And this whole diagram here is sometimes called the pain neuromatrix. It's this collection of brain functions that produce the pain experience. Now let's add something else. The brain also regulates pain. So it can choose to listen to something or not. It's like if you're in the living room at home and the TV is on and somebody is talking to you, which do you listen to? If you listen to the TV, you might miss what the person is saying. But if you listen to the person, you might miss what's happening on TV. So the brain has the ability to switch channels. And this downward arrow is that. The brain can listen to the pain signal or not. So the brain gets into this competition where it can choose to inhibit the pain signals, but also in the spine there's this phenomenon called wind-up, which is over time, second pain starts to build because those nerves are becoming progressively more sensitive. So all these factors are contributing to the pain experience. Now, while this is kind of complicated, let's switch to something simpler, which is a little closer to a patient's experience. A better way to think of this might be that pain is like an onion in that it has multiple layers. And to understand it, we have to understand all of these layers. So pain often begins with tissue damage from an injury or disease. And so there's some sort of tissue problem, a broken bone, torn cartilage, a herniated disc, a disease process, arthritis. Something biological may get it started. But then there can be a second layer, and that's, well, the first type of pain in the bullseye is pain from nociception. There's also neuropathic pain, which is due to nerve injury or dysfunction. That's when a nerve may get pinched or cut or damaged somehow. Neuropathic pain is confusing because it's someplace else. Like if a person hurts their back, the injury is there, but the pain travels down their leg, and that's neuropathic pain because there's a nerve pinched in the back. And the confusing part about neuropathic pain is you often don't feel it where the injury is. So if you have a back injury and you pinch a nerve in your back, you may have pain in your leg. Now that's real pain, but it's neuropathic pain. With neuropathic pain, you don't feel it where the injury to the nerve is. You feel it where that nerve goes. So if you pinch a nerve in your back and that nerve travels down your leg, you feel pain in your leg where that nerve goes. So it's confusing because you often feel that pain someplace other than where the injury is. Next, third layer of the onion is stress-related muscle tension and spasms. When you're injured, your reflex is to protect yourself by bracing your muscles to hold that part of your body still. Just like a cast may immobilize your body, your muscles do the same thing. You try to immobilize your body to protect it while you heal. Now, in the short term, that's not a problem, but if you brace your muscles for days and weeks, months, years, over the course of time, muscle tension pain starts to become a prominent source of the pain. And so, whereas the first part of pain in the bullseye might be to bodily tissues, to a bone or cartilage or a disc. And the second part was nerves. This is in the muscles now. So it's a different type of pain. And it can be just as painful as the other types. Next, when a patient is in pain, they often have a difficult time sleeping. Now, if you've slept 8 hours and feel rested, pain can still be hard to cope with. But if you've slept 2 hours, pain is just overwhelming because you're too exhausted to deal with it. So insomnia and exhaustion make pain worse too. Lastly, over the course of time, people get frustrated. They worry about the future. They can get depressed or down, maybe angry, scared, and have negative thoughts. And all of that adds to your suffering. So this completes the onion. All these different layers contribute to a patient's pain experience. And each layer requires a different type of treatment. So, all these different layers contribute to a patient's experience of pain. And to understand what's happening with a particular patient, we need to perform a biopsychosocial assessment of that patient's pain. To assess a patient's pain, we might begin by exploring the patient's reported pain intensity and distribution. So how much pain do you feel and where? We can also ask the patient about pain variability over time. How high does it get? How low does it get? Does it stay the same all the time? What's the range of pain experiences that you've felt? Over time, patients start to think about their pain, and their thoughts and beliefs about their condition may be helpful or unhelpful. And so it's important to assess how a patient is thinking about their pain and their medical condition, and whether those beliefs are helpful or not. Over time, many patients start to have stress-related symptoms because pain is a stressful condition. And so it's not surprising when stress-related symptoms appear. Over the course of time, patients may get depressed. They just feel down and sad. I mean, why would you be happy to have pain? There might be other feelings too. There might be anxiety about what the future holds for you. Anger about what has happened to you. Sometimes pain is associated with a traumatic experience, like a car accident or some other type of accident. Sometimes there is a traumatic element to the pain onset, and so it's important to assess that. We also have to understand how a patient copes with the world and how things are going for you. Like, do you feel supported by your environment, by your family, by your employer, by your medical professionals, or is there conflict in one or more of those areas? All of this helps us understand the patient's experience. And all of this contributes to how well a patient can tolerate pain. So, to treat this, there is what's called interdisciplinary care, where you have a spectrum of different types of treatments. So, to treat pain and most medical conditions, there are basically 4 categories of treatment. First of all, there are surgeries and injections, or called interventional injections. Those can sometimes be helpful. There are various sorts of medications with pain. Typically what's thought about is opioid pain medication like hydrocodone or oxycodone. But those are less helpful over time, and there are many other medications that might be more helpful. But that's another discussion. There are various physical therapies that might be helpful. That includes physical therapy proper, chiropractic, occupational therapy, acupuncture, yoga. There are a variety of things that may be helpful in this domain. And lastly, there are behavioral therapies. Now, behavioral therapies are things that you can do for yourself to manage your own condition the best possible way. So, as an alternative to opioid pain medication or other treatments, there are behavioral therapies. Let's think about what those might be. These are all brain-based interventions. So for the arousal and inability to sleep, there's relaxation training and behavioral sleep treatments. Actually, the behavioral treatments for sleep, most research studies shows that this works better than pills. Related to this is something called biofeedback, which is a type of treatment where a computer can give you feedback on your ability to voluntarily control bodily functions. There are various therapies for emotions. There are also treatments like hypnosis, and although that sounds kind of like hocus pocus, hypnosis is actually a treatment that can be helpful and has a strong scientific research basis. Helping patients to solve problems related to their pain that occur in their own world, with their job, with their family, with their ability to do things they want to do. That's an important behavioral treatment. There are what are called cognitive therapies, pain education, helping patients understand their pain and how to think about their pain in a more helpful way. There's a thing called mindfulness therapy. We talked before about how memories of pain begin to influence how you're experiencing your pain now. And mindfulness therapy is about trying to think about what your pain is right now and not feel limited by your memories of pain, which can affect people negatively. Then finally, there's self-management of your condition. There's a variety of things you can do to manage your condition better. And also attentional shifting. Being able to think about something else helps. If all you have to do is think about your pain, you're going to be more distressed. If there's something that you find interesting that you can think about, that's a good thing to do. Conclusions. The biopsychosocial model is a widely accepted model which is a better way of understanding patients with complex medical conditions. By recognizing that patients have biological, emotional, and social needs, all of these can be addressed. This is better care.